I'm Victoria Garcia Albea. I'm a dermatology nurse practitioner. I work at a hospital called Lahey Clinic. It's outside of Boston, Massachusetts. I have been in medical dermatology since 2006. I did a dermatology nurse practitioner training program at the Lahey Clinic in 2006 to 2007, and now I am the director of that training program. And I also am the lead nurse practitioner in our Hansen's disease clinic, which is leprosy. So that's kind of like a unique thing that we have at my hospital. And I'm also on the Elevate Derm leadership board. So I get to be involved in all of the Elevate meetings. I am a co-medical director for the fall meeting, which is coming up in November, and it'll be in Austin, Texas. Today is all about JAK inhibitors. It's the JAK Institute, so the name pretty much explains it. So obviously we've covered topical JAKs and oral JAKs, and I think one thing that's been really resonating, not just here at this conference, but in the last several years even, is focusing on safety of oral JAK inhibitors. So they came to market and we loved them right away because they're so efficacious. They work very rapidly for many, many diseases. But I think we were initially hesitant because of the black box warning, and we still have to discuss it with our patients and respect the black box warning. But now that we have so much data on safety, not just efficacy, I think that the urge from a lot of these experts that we've been hearing from is to not be too hesitant to use the JAK inhibitors when they're appropriate. So we talked about certain parameters to keep an eye on, so certain lab monitoring that is known to be a little bit off initially and then to normalize over time. So just keep an eye on that trend, and then if that seems to be persisting after 12 weeks, you may want to look into it. So certain monitoring that we would have initially had a gut reaction to stop the medication, now it's like, okay, we're going to keep an eye on it and see if we can maybe add some dietary changes so that patients maybe bring their lipids down a little bit more naturally, things like that. Absolutely, thank you. So a couple of things that are very important, and we've actually seen them still be persistent in the clinical trials. So I think that we all respect the history of blood clots if they're unprovoked. If the patient has a history of unprovoked blood clots, that is something to delve deeper into. If they have a history of malignancy, you want to collaborate with oncology and see if they're still a potential candidate for a JAK inhibitor. And then infections. So we still have to screen for tuberculosis annually. That's pretty much across the board for all of the oral JAK inhibitors. So that's one of the most standard tests that we run is a quantiferon gold or a blood test for tuberculosis. And then generally, sort of like the biologics, we'll do an initial screening for hepatitis B and C. I usually screen for HIV risk factors. So if patients have risk factors, I'll screen them for HIV, or if they want to be screened for HIV, I will check it. Not everybody does that. And then we're generally doing CBC with DIF, CMP, lipids at baseline, and then 12 weeks in. I think that, so I started practicing in 2006, and in 2006 we were just getting the biologics for psoriasis. Humira came out in 2008, so we were just on the cusp of having these amazing breakthroughs for controlling psoriasis. And I think that we used to really only look at skin disease that we could see. So if patients looked clear, we considered our job was done. The last couple of years, we've been really actually having more of a dynamic conversation with patients, finding out how do they think their disease is? Do they actually think they're controlled? Because so much actually is beyond what we can just see on the skin. So are they still itchy? Are they still having pain in whatever condition they have? So I think we're really incorporating patient experience and patient input and patient perceived quality of life much more than we used to.